Hello, this is Jeff Swenson speaking to you from Salt Lake City, Utah. Welcome to Safe Ultrasound and our step-by-step approach of the simplified adductor canal block. In our previous tutorial, we discussed the traditional adductor canal block as being a perivascular injection. As seen in this image, the simplified technique does not use the SFA as a landmark for injection. Instead, a fenestrated needle is positioned across the tissue plane between the vastus medialis and the sartorius muscle. The advantage of this technique is that it does not require proximity to the vessel and that the tissue plane between the vastus medialis and sartorius muscle is easily identified with ultrasound. The simplified adductor canal block is performed using a three-step approach to identify ultrasound landmarks. First, the transducer is positioned over the vastus medialis at the superior pole of the patella. The transducer is then moved posteriorly until the tissue plane between the vastus medialis and sartorius muscles is visualized. While keeping this tissue plane in view, move the transducer superiorly until the SFA is visible in the far field of the image. The fenestrated needle is then advanced across the tissue plane between the vastus medialis and sartorius muscles. Ideally, the needle is positioned so that 1 centimeter of the fenestrated segment is on each side of the plane separating the vastus medialis and sartorius muscles. This image shows the sensory loss that is produced by adductor canal block performed at the distal third of the femur. These borders of sensory loss are very similar for both traditional and simplified adductor canal block. Note that the upper limit for sensory loss is about 7 centimeters above the lateral joint line and about 7 centimeters above the medial joint line. Anteriorly, sensory loss reaches approximately 4 centimeters above the superior pole of the patella. Knowing the sensory distributions of the adductor canal block and simplified adductor canal block is important when deciding which surgical procedures can be treated using this block. Two of the most common surgeries that benefit are total knee arthroplasty and anterior cruciate ligament reconstruction. We have included a number of other operations that also benefit. An important clinical note is that many patients or some patients may have residual anterior, lateral, or medial pain despite successful adductor canal block. Many of these patients will achieve relief from a sciatic nerve block in the upper border of the popliteal fossa. We postulate that this may be due to some aberrant innervation from the sciatic nerve. Under these circumstances, even a very dilute injection of 0.1 to 0.125% bupivacaine at the popliteal fossa will provide analgesia. However, these patients must be then advised that sensory and possible transient motor loss may occur below the knee. As mentioned earlier, the tissue plane between the vastus medialis and sartorius muscle is most easily imaged by positioning the transducer over the vastus medialis and moving medially. Many of the nerves supplying the knee exit the adductor canal to the deep surface of either the sartorius muscle or vastus medialis muscle. While injection into these tissue planes may be performed using a single beveled needle, our success with this block has been greatly improved by positioning a fenestrated needle across this fascial plane. This 20-gauge echogenic fenestrated needle has side ports extending on opposite sides for 2 centimeters near the tip of the needle. The actual needle tip is pencil point so that outflow from all side ports is equal when the lumen is pressurized. This video shows the 18-gauge introducer that is used with the pencil point needle. Note the outflow pattern when the needle is pressurized. This video shows simultaneous ultrasound images and transducer position as the tissue plane between the vastus medialis and sartorius is located. Note that imaging starts over the vastus medialis near the superior pole of the patella. The transducer is moved medially, and the first tissue plane visualized is that between the sartorius muscle and the vastus medialis. If we move the transducer proximally, the SFA and femoral vein are visible. The transducer is then moved back to the distal third of the femur to perform the block. White arrows illustrate the position of the tissue plane between the vastus medialis and sartorius. In our final example, we see simultaneous views of the ultrasound image and transducer position. White arrows mark the vertical position of the fascial plane between the vastus medialis and sartorius muscle. The block needle is inserted in plane, and there is tenting of the fascia as the pencil point needle crosses. With approximately 1 centimeter of the fenestrated needle on either side of the tissue plane, local anesthetic is injected and spreads on both sides of the fascial plane. After injection, local anesthetic is visible on the deep surfaces of both the vastus and sartorius. Thank you for watching, and enjoy the rest of the videos on safe ultrasound.